Same study tips. There's some summary tables. I want you guys to focus on those. Calculations, know when and how to use them and when to use conversion factors. And then there's pathways that I talked about. Not knowing, there are two that I told you don't need to know the steps for. There are certain elements that I told you to focus on for two pathways, and we're going to talk about those a little bit later on. But to get started, I have a question for you guys. What is true when pKa is equal to pH? 50% of the drug will be uncharged or unionized and will cross through the gut wall. That means the other 50% will not, because it will be charged, right? Make sense? All right. What about one person give me one characteristic of zero order kinetics? One person. Yes.
Oh, sorry, I was just thinking.
Oh, no. Yes.
Alcohol.
Alcohol is what?
Zero order kinetic.
It's a yes. That's an example.
Oh, there's no example.
No. That's perfect. Thank you. That helps. You might see that again.
It's metabolism happens. It's not dependent on the concentration. The half-life doesn't. Not half of it's going to disappear at a certain time.
Correct.
It'll just max occupy its enzyme, whatever.
You gave all the answers. Perfect. So for zero order kinetics, there's a constant amount of drug that's metabolized per unit time, and that's because the systems, the enzyme systems, are saturated. And so zero order kinetic drugs do not have a true half-life because of this. All right? Questions? All right, so this block is pharmacology, and so we talked about what pharmacology is and that there are two major subcomponents of pharmacology, and that is pharmacokinetics and pharmacodynamics. Pharmacokinetics is the study of a drug's absorption, distribution throughout the body, metabolism, and excretion. We know that a drug's absorption is its movement from the site of administration into the bloodstream. And of course, that depends on a number of characteristics of a particular drug, in addition to how the drug was administered, the size of the drug, the lipophilicity of the drug, and also the pH of the drug, because the pH will affect the drug's ionization. And so, when we take drugs given orally, it's very important that we understand and know the different pH values for the entire GI tract, because that will dictate which drugs are absorbed where. All right? Does that make sense? All right. So if we talk about an acidic drug being absorbed in an acidic environment such as the stomach, we already stated that when pH is equal to pKa, 50% of the drug will be uncharged, 50% charged. But we take the example here for aspirin. Aspirin has a pKa 3.5. The pH of the stomach is 1.5 to 3.5. So we know in this case that more than 50% of the drug will be uncharged. Very little will be uncharged, in fact. And so an aspirin will cross the gut wall and interportal circulation, being digested through the stomach. So acids typically are absorbed in an acidic environment such as the stomach. Now, if we take this pH, was the pH 7.2, which is found in the small intestines, aspirin will be charged and it will not cross the membrane. And so for acids, we know that when pH is less than pKa, 1.5 is less than 3, most of the drug will be unionized and will cross through the gut wall through diffusion. Any questions about that?
Would, in the future, when you get like a range of pH in the range, like stomach, do you use the lowest?
Yeah,
possible range?
yeah, that's gonna tell you really what's going on, the lowest range. That's a good question. Yes.
So I guess does it continue to shift until it equalizes because it's a register?
Yep.
Okay.
Yep. It does. Yeah. Any other questions? All right. So we know that the pH of the urine is mildly acidic under normal conditions. And so if we have acidic drug that's induced acidosis, for example, aspirin toxicity, we know that we give sodium bicarbonate, and what that's gonna do is that's gonna interact with the aspirin. It's gonna make the aspirin charged, it's gonna deprotonate that aspirin, and then that's gonna cause the aspirin to be excreted by the kidney, and it will not be reabsorbed because it will be charged. And if we have a basic drug that we want to get out of our system, we will acidify it with an acidification drug. And what that's gonna do is gonna do the same thing. It's gonna it's gonna protonate the basic drug in this case, and the drug will not be reabsorbed. So here is the graph for a single oral administration of a drug. We have time on the x-axis, drug concentration in the blood, y-axis. We have the onset. This is where the drug enters the bloodstream at its minimum effective concentration and its maximum safe dose, that is the therapeutic range. And then we see all the components of pharmacokinetics. Absorption here, it's distributing, and then it's being metabolized and being excreted as the curve is going down, meaning the drug is being eliminated from our system. So we talked about drug distribution models, and in the two-compartment model, we have that central compartment, which includes the organ shown here, in addition to the peripheral compartments, which includes the brain, the muscle, and the fat cells. So most drugs follow the two-compartment drug distribution model. So once a drug is absorbed into the body, the next question is how much of it actually reaches systemic circulation, and that is the definition of bioavailability. And so bioavailability is the amount of drug that reaches systemic circulation in its active form. We compare all drugs bioavailability to an IV administration of a drug, because we know that's going to put 100% of the drug into the blood, because it's not going to undergo any metabolism via first pass effect, which is what we'll talk about that a little bit later on. So all drugs have a predetermined value of its administration through other routes besides IV. So oral, IM, sub-Q, all of those are predetermined based on properties of the drug. So we have an estimate of the amount of drug versus what's given, which will end up in the bloodstream. So since 100% of a drug is available when given IV, if you have drug X, 100 milligrams per milliliter, that is administered, that means all 100 milligrams of drug X will enter systemic circulation. And so volume of distribution is a theoretical value that essentially is telling us how much of a drug, what it's doing in the body, whether it's staying in the blood or it's leaving the blood. If it leaves the blood, that means that it has properties such as lipophilicity, and that means the drug is going to have a higher volume of distribution. If it's highly protein bound, it's gonna have a low volume of distribution and it's gonna remain in the plasma. So when we look at the equation of volume of distribution, we look at bioavailability, which is F times the dose of the drug over the initial concentration of that drug in the plasma. So with those values in mind, when we plug in the numbers, we see that volume of distribution for this particular drug is 8 liters. That's a moderate volume of distribution for a drug. And what that tells us is that the drug is likely leaving the blood and entering the extravascular spaces. And so when you see these calculations, make sure that you get the units the same and the measure or metric for volume of distribution will be liters or liters per kilogram is how you typically see it. Yes.
Sure. How many are we expected to memorize the equations?
No.
No.
Is that okay. Any other questions? Yes.
So we didn't know this formula, sir?
No, you don't need to know the equations, but if you can remember it, but it's gonna be on the exam in the top box. You know, there's like a section for you guys to see this over here. Yes.
You said 8 liters was, meaning like the drug has a high propensity to go into the
Tissue.
to the tissue. Is there like a delineation line, like lower than that? Is that important or not really?
So I've tried to find that specific answer, and like there are some drugs, like I forget what the drug is. I think it's a type of antibiotic, and it has a volume of distribution of like several thousand liters. So that means it's just like very lipophilic, so it like stays in the tissue. And then there are some drugs that have point something liters volume of distribution. So I don't know where that cutoff is, but it can be a very big range. And of course, we know we don't have thousands and thousands and thousands and thousands of liters. So that's just a theoretical calculation telling us that the drug is highly lipophilic. Does that make sense? That answers the question. Any other questions? And again, this is just showing what I mentioned. If a drug has low volume of distribution, it's bound to plasma proteins, particularly albumin. If it has a higher volume of distribution, it's lipophilic and goes into the tissue. Now, when you guys have patients that have like liver and kidney disease, that's going to affect their ability to make plasma proteins. So that also will affect your drug dosing that you give them because, for example, there are some drugs that are highly protein bound, but they have a low therapeutic window. So if you have less protein for the drug to bind to in the blood, that means that drug is going to be active. So that means that you're going to have too much drug active in the system, and then that could cause toxic effects on the patient. So that's one thing that you're going to have to definitely consider when you're prescribing patients to drugs to patients that have like liver and kidney disease, along with a number of other variables that are important to consider. That's one of them, particularly when you're prescribing a drug that is highly protein bound and has a low therapeutic index. Was there another question? No. Okay, we have reached metabolism of pharmacokinetics. First pass effect or first pass metabolism occurs once a drug is given orally and it crosses the GI, the gut wall, and reaches portal circulation and is metabolized by the liver. the amount that's left over is the bioavailable drug. And so that also is a predetermined value for each drug. And as I mentioned last class, some drugs have a very low first pass effect, like ibuprofen. First pass effect is like only 10%, so 90% of the dose that you're given is available for most patients. In terms of metabolism, there are two main pathways. Phase 1, we know that's achieved by the cytochrome P450 enzymes through reduction, oxidation, and hydrolysis reactions. Phase 2 are conjugation reactions through glucuronidation, sulfation, and acetylation. And with these two modes for phase 2 is the reaction type that gets a drug much more polar so it can be more easily excreted if it wasn't able to be achieved during phase 1. So phase 1 will introduce or expose a functional group. Phase 1 is typically called functionalization, and phase 2 is called conjugation, because that's definitely gonna get a drug inactivated and make it so polar that it will be removed from the body. And in terms of a drug activity upon metabolism, you have inactive metabolites, metabolites of drugs that retain the same activity, and also drugs that have increased activity upon metabolism. And then you have prodrugs. We talked about the example of valcyclovir. I misspoke. I said it was for HIV. It was for herpes simplex 1. And once it is metabolized to acyclovir, that is the active drug. There are drugs that are both inducers and inhibitors of metabolism. We know when a drug induces metabolism, it's going to decrease the pharmacal action of that drug and a potential co-administered drugs. Yes. I'm sorry, can't you?
On the pro drugs, does, if you were to administer that like intravenously, does that mean it wouldn't work since we metabolized first?
So there are, I don't know about for this specific drugs, but there are some other means that drugs can be metabolized once it's given IV. But this drug, what will happen is it will just have to go to the liver, and then which is kind of defeating the purpose for IV administration. But I mean, I don't know if they would ever give this drug IV. But there are also sometimes some other components in the blood that do metabolize drugs. I can't think of any example, but that's a good question. So this drug would have to go to the liver first in order to be metabolized into the active compound. Any other questions? In terms of inhibitors of metabolism, inhibitors will reduce the activity of the enzyme and thereby cause potential increase in pharmacological action of a drug because it's not being broken down, and that can also lead to potential toxic effects. So, for example, if you have drug here, if you co-administer with an inhibitor, what's going to happen is, so let me back up. Under normal conditions, the drug is metabolized by the CYP enzyme to an inactive metabolite by itself. If you co-administer an inhibitor, what's going to happen is that's going to inhibit this enzyme, this drug, which will cause increased levels of this active drug and potentially this one as well. And so that's going to cause the increased likelihood of side effects and drug toxicity because the drug is not being broken down. Yes?
And then sir, for a prodrug, it would be the inverse for both of those?
Yep. And then for an inducer, drug given with inducer, that's gonna induce this enzyme, meaning that this drug is gonna be metabolized faster, decreasing the level of active drug, and then that's gonna cause less than therapeutic effect because the drug is being broken down fast. All right, so talked about chirality. We know that is non-superimposable molecule mirror images as shown at the bottom here. You have the R enantiomer, which is right, S enantiomer for sinister, which is left. When there's a mixture of enantiomers, that's called a racemic mixture, and the different enantiomers possess different properties. We've talked about this even beginning in the first block of biochemistry. In the case of warfarin, the S enantiomer is up to 5 times more potent than the R form. And so that's just important to note. Previously, in pharmacology, they weren't able to isolate the different enantiomers, but now they can. Now science is advanced, so they can select out the ones that have the greatest benefit and less toxic effect. All right. So we already talked about half of this in terms of the different types of kinetic metabolism. We talked about zero order kinetics. First order kinetics, a constant fraction of the drug is being broken down per given time. First order kinetic drugs, which is what most drugs follow, do have a true half-life. And in this metabolism, the systems, the enzyme systems are not being saturated. And so, as was mentioned earlier, ethanol is an example of zero order kinetics, in addition to aspirin, phenytoin, and fluoxetine. In terms of drug elimination, kidney is the primary organ of drug removal, in addition to the lungs, the feces, and even the skin. And so, drug clearance is the measure of the removal of a drug from the plasma per given time, and clearance and volume of distribution of a drug determine a drug's half-life. And there are many different ways of a drug being cleared. You have hepatic transformation, which is both phase 1 and phase 2 metabolism, and then renal clearance and biliary clearance. And so a drug's clearance from the body is the sum of all elimination pathways, meaning that it is additive. And so the primary means is the liver, but then of course you have the kidneys and other organ systems. And the total systemic clearance is based on the organ's blood flow and the efficiency of a drug being extracted from an organ. So when we look at the half-life of a drug, and that is the time necessary for a drug's concentration to be decreased by half, that is based on the volume of distribution and clearance. If we look at the example of ibuprofen, the half-life is 2 hours. So the initial plasma concentration is 800. After every 2 hours, the drug will be decreased by half. And so the general rule of thumb is that a drug will be completely eliminated from the body when given one time orally after 5 half-lives. And so if we're giving continuous infusion of a drug, 5 half-lives will give us a steady state, and the steady state will be equal to the amount of drug entering the systemic circulation is equal to the amount of drug being cleared from the body. So again, 5 half-lives is the general rule of thumb. So for ibuprofen, half-life is 2 hours. The drug will reach steady state 2 times 5 equals 10 hours, or the drug will be completely washed out if only given one time. So if we have another drug with a half-life of 7 hours, how long will it take that drug to reach steady state? If the infusion rate is 30 milligrams per hour, we take 7 times 5, and that gives us 35 hours. Any questions about that?
I was trying to see how many of those questions.
I mean, not 45. No. Maybe a couple, maybe. So here are two different graphs showing a drug's elimination. Now you're familiar with the one on the left. This is a single oral dose. And I also wanted to show an IV dose. We see for IV at time 0, we've reached the peak and it just starts to decrease after that. So I just wanted to show you the different profiles of the drug administration. And you see that both drugs are cleared in 2 days. So oral administration, IV administration. Any questions? All right. So in terms of pharmacodynamics, now we were looking at what makes a drug effective, and that is a drug's efficacy. And what efficacy is basically how well a drug works. And so when we're looking at multiple drugs, we can compare the drug's efficacy and the potency. And we compare the potency by looking at the EC50, which is the effective concentration at 50% of the Emax, which is the efficacy. And so as clinicians, you guys will need to know that drug's efficacy is more important than the potency. The potency is just the amount of drug you need to elicit an effect. So if looking at this graph, we see drug concentration, y-axis, semi-log scale, percent response. The Emax is the same for all of them, meaning they have the same efficacy. However, the potency is different for all of them. So A is more potent than B is more potent than C, meaning less of A is needed to elicit a response than B than C than D. All right. So putting all of that together, that gives us our pharmacokinetics and pharmacodynamics. With pharmacodynamics, we talked about the major drug targets, and those were these receptor systems listed here. You guys already know the mechanism of the GPCR proteins. Don't forget that. You will likely see some questions for these on the exam. But wanted to again mention for this pathway, which is involved in cell growth, differentiation, and metabolism. This pathway, I don't want you to know the steps. I just want you to associate these full name intermediates with this pathway. All right? Any questions? What's the take-home message for this pathway? Somebody say it loud. What are those? Perfect, that's correct. Tens and terms are the ligands that bind here to elicit whatever pathway is elicited, either immune function, cell growth, or inflammation. All right? Any questions about that?
Can you repeat that, sir? Can you repeat that?
Yes, so tens and terms, these are the ligands that bind to these receptor systems to elicit the pathways, be it immune function, cell growth, or inflammation. That's what these are involved in. Right? Any questions? For ligand-gated ion channels, those allow for the movement of ions across intracellular space or intracellular pore. For example, the gamma aminobutyric acid A, GABA A receptors These receptors are composed of 5 subunits, 2 alpha, 2 beta, 1 gamma. There's 3 different types. GABA A, GABA C are both ion channels, and GABA B is a G protein coupled receptor. GABA is the major inhibitory neurotransmitter in the nervous system, and it's found throughout all areas of the brain essentially. Here is a diagram of the transmembrane subunits, 2 beta, 2 alpha, 1 gamma. GABA binds between the alpha and beta subunit, causing the influx of chloride ions, which causes hyperpolarization. You also have benzodiazepines, which bind to the gamma subunit, and flumazenil, which is a benzodiazepine antagonist. It also binds to the gamma subunit, but it binds to an allosteric site that then the benzodiazepines bind. All right. All right. Now a couple more calculations. So you guys are prescribing dosage of 0.150 milligrams of T4 synthroid in tablet formation that are contained in 75 microgram tablets. Of course, you guys know the units are different, so if you see a question like this, make sure you convert to the same unit of measure, and it should be easy peasy. You will come up with the number of tablets. May or may not be a whole number, don't be alarmed, in case you see a non-whole number, all right? Any questions about this calculation? Yes.
So if you don't get a whole number, do you round up or down?
You don't
Oh.
round the question, the answer will be
Okay.
the exact, will likely be the exact number that comes in the calculation, if you see this on the exam. All right? All right. Then for the IV piggyback, now remember this equation, don't be fooled if you see a bunch of other numbers. You may see more in this information. These are the only set of information you need. The total infusion volume, which is 50, drip factor 15, total time 5 minutes. And so that will give you 150 drips per minute. All right. Any questions about that calculation? Yes.
Are we gonna be converting it into drops per second, so it didn't get a drop?
Drops per minute. Drops per minute. Any questions? All right, and then these summary tables we talked about, just to introduce you guys to the different names of the many different drugs that you guys will be learning to treat depression, anxiety, and for blood pressure issues. Here, I will focus on this table, and then also the controlled substance summary. One thing I want to mention that one of you scholars let me know that last month, at the day before or after I taught this lecture, the Halt Fentanyl Act was passed, and so that meant fentanyl analogs will move to Schedule 1, but the fentanyl drug itself is still Schedule 2. So, any questions about this material? All right, so I will be available. You guys know how to reach me. I'm sure you're gonna do great, but if you need me, please contact me. All right.